Welcome everyone to our next FHIR series hosted by Digital Square. For those of you new to Digital Square, we support governments, innovators, and donors to support country digital health programs. And one of the ways we do this is hosting webinars like this to support adaptable, interoperable tools that are designed to work seamlessly together. This month's session, as you all probably know, is on case reporting, where we're going to spend some time exploring the common needs for a case reporting system. And using an example specification, we'll see how to implement the full stack of case reporting using FHIR specifications and tools. I know this is a pretty packed session, so I'm going to run through the rest of this, but some house rules. This webinar is recorded and will be posted on our wiki along with the slides. We ask that you mute yourself during the presentation so we can hear the speaker clearly. And please raise your hands during the Q&A session to ask a question, and I'll go ahead and call on you. If you're not comfortable with raising your hand or speaking up, please throw your questions in chat. We also have a Google Doc if you want to throw your questions in there or see any sessions we've done in the past. All right, without further ado, let me introduce Jose. I think most of you know him by now, but Jose is a data management standards and interoperability expert that has worked in the sector for over 20 years. He is the co-chair of IHE Pharmacy, as well as an avid supporter and contributor of FHIR. And since 2009, he's been contributing to the global healthcare standards HL7, IHE, and ISO. He's also facilitated the launch of HL7 and IHE work groups in Brazil, Portugal, and Belgium. All right, Jose, over to you.
Thank you, Brenda. Hi everyone. So for this session, indeed, we will be talking about the case reporting, which is more and more of an emerging topic. And while preparing this session, we realized that the possibilities or the scope of case reporting and the amount of tooling and the amount of knowledge that is available out there, it was really a lot, which is good. So it required us to see how to best present this. So in the course of today, we will cover, I think, all the basic aspects, but without going into the detail in the aspects that for which we will have the dedicated sessions. So let me just be a bit more concrete on this. Let me see if I can share my screen. I presume you can see my screen.
Yep.
So first thing we will do is to do some sort of scoping considerations for case reporting. So what is case reporting, and what kind of mechanisms are we talking about? What kind of functionalities are we after when we do case reporting? Then we will have to go through some fundamental aspects of FHIR that are relevant to this. So we had all these sessions, the FHIR sessions of FHIR, basics, FHIR terminologies, FHIR profiling. We had those sessions. You can always watch the videos, but for this session, there is a couple of things that are quite relevant. So I will just rather briefly go through those fundamentals to make sure that we're all on the same level, on the same page to when we talk about resources, resource instances, profiles, and etc. So that's one part of our discussion. Just one note before that. So in the first part, we will already be looking forward to see if you have some examples of what case reporting means to you. So we want to make this more interactive with your ideas and that can respond. Then we go a bit in depth of what case reporting purposes and what the impact of those functionalities mean for us. So what's the impact of having a lifelong case reporting versus a specific time window case reporting? What's the impact of having a patient-centric versus a population-centric case reporting? So those things we want to elicit that knowledge and to see what also do you think of that. Actually, we could have this feedback here. So we have some challenges that we would like to hear from you. I think actually this Q&A is before, but I will see. Then we go into the case reporting architecture. So this is a collection of practices, tools, and architecture overviews that we have from current implementations and from past experience. And we'll look at this into what are the functionalities that we have, what kind of systems are available, and what data flows between the different systems. So this is, I think this is going to be the most important part for designers, because then designers can see, do I want this, do I want that, do I want the analytics part, or do I want the event reporting? Do I want to capture data as new, or do I want to get legacy data on board? So those are the things that we will be discussing. Then it's a bit more onto the FHIR technology fundamentals again, but now really specific for case reporting. So we'll be talking about the FHIR questionnaires. So it's a questionnaire and questionnaire responses. Those are resources that we will use often in case reporting, and the corresponding structured data capture. We'll see what that is. It's an additional specification in FHIR. And then very briefly, we will go into the implementation aspects. So we will go back to layer specification, and we'll see some points about the tooling, all of which we will follow up in future sessions. For example, the tooling for analytics, we will follow in the analytics session, the tooling for how to implement this. We will see a bit here, how do we put, for example, a questionnaire for case reporting. We will see today how we put that into an implementation guide. That's the easy part. But we want this session to be about connecting the dots and seeing what is out there, and not necessarily a detail on one specific aspect of this. This is a proposed agenda, but this is quite open for discussion. I mean, not the agenda, but the topic. So feel free to interrupt, feel free to raise the hand, feel free to just speak up. I might not see any hands raised if I focus on the slides. So please just jump in with any thoughts, any ideas, or any aha moments if you have them, or if any things that you think that is not well described or is not correct, just jump in. Any things that trigger your thoughts. Well, before this, and at any moment, besides the Q&A or the interactive part that we have, if you want to propose some discussion things, you know, some, like, it would be good if we discuss that part, or how do we deal with anonymization or the identification of patient data. All those things, bring it up. But if you don't see a moment to bring it up, just put it also in the Google Doc, because it's good for us to keep track of what we are discussing from you. And it's also interesting for us to plan the next sessions. If we see lots of people saying, oh, we really need to see how we do patient matching, or how do we do anonymization of data, then we might use that as a trigger to go in depth in a future webinar. So just the usual remarks, disclaimers. FHIR is a registered trademark. The fact that we are talking about FHIR here does not mean that this is a FHIR or an HL7 endorsed course or an official training. There are several training opportunities. Feel free to go to hl7.org/training for figuring out if you want to have more in-depth training. All the sessions that we give, they are just connecting the dots sessions. So if you want to have more formal training or more in-depth training, you're always invited to seek out those courses. This presentation, everything in this presentation, and the tools that I use to do this, everything is done with freely available materials. We are kind of picky with our licenses, so we use only things that we can freely use and that you can freely copy. The only thing that we have is for these training materials, we are using some materials from other people. So in this slide deck, I just used some slides from HL7. So this presentation comes with a similar license, so it's a Creative Commons license. So okay to share. Please share. Please reshare. Try to give the credits when sharing. Oops, I was on a slide. So for the case reporting, what is it about the scope that we want to do? By case reporting, the starting point of our discussion is that for us, it's about data exchange mechanisms. This is because we're talking about FHIR, so we're talking about data exchange. It's data exchange mechanisms for acquiring, maintaining, and using data about the patients, typically about the patient's case, evolution and treatment, etc. Let's go a bit into more into more complete examples. So it can be following up chronic conditions. I don't know if HIV qualifies as a chronic condition, but diabetes, for example, qualifies as a chronic condition. There are some long-term conditions like skin cancer, some diseases that are really so long-term that they are chronic diseases or chronic conditions. So case reporting can be about following that. One very outstanding, currently outstanding, sadly outstanding example of case reporting is infectious diseases. So regardless of how long-term is the disease or the condition, we want to follow up the cases to see where the cases are there, who's getting infected, how long are people being treated for the disease, how long is the infection, reinfection period, all those things as we study the evolution of the disease or the evolution of the populations with regards to the disease. So that's another use of case reporting. The other thing is, of course, the consequence of that is the treatments. So sometimes case reporting can just be about following up treatments to see if on a population basis the treatment is being more effective, less effective, or if there's any comparison that we can do between populations. This is not about clinical trials at all. It's just about following up on the cases and any other. As I was typing these things, I was thinking that we could have case reporting for pregnancy, as we follow the pregnancy from the beginning, from when the patient is known to be pregnant until the delivery or until a miscarriage. So these are the kinds of things that we can do for case reporting, or a kind of scope where case reporting can apply, or where we will apply this. Just as you've seen similar pictures before, just wanted to highlight where we are. So if we look at enterprise architecture, just to see what kind of topics we are discussing, and I thought I had this highlighted, but I don't. My apologies. So when we talk about our specifications, we are talking about the physical data model. That's all about FHIR. It's a physical data model. So what data do we exchange? But we're also entering a bit into the system design, because we have some architectural components. And not only on the technical system, but we also have to abstract that a bit. So we don't really go into the business process model and the business logistics and the conceptual data model. That's something that we don't really go through. But we are in the space of logical data definition. So if I say pregnancy is a condition that requires coding, and pregnancy has a duration. So these attributes, this is logical data modeling. Physically, we can say this is this data type or that data type. So we are pretty much in this region, in the logical data model, application architecture, physical data model, and system design. And of course, the data definitions that come with it. So this is where we are in terms of enterprise architecture. We will see how that relates to how we design systems. Just to set the tone, what we will be addressing today follows this kind of pattern, which at this moment is supporting some good discussions. So by this, I mean, I do not know if this is complete or it should be upside down, but the case reporting approach that I've seen being implemented pretty much follows this. So we have a phase of getting data somehow, maybe it's already there. The other thing is, if we don't collect data on purpose, then we have, or even if we do, we have to extract data, we have to acquire data and extract it to a format that we can use. And then we put that into a data pool where we can do all sorts of operations on the data. And from there, we do the data usage. So I think the key thing is that we have a data pool that is fed by some data acquisition mechanisms that come from whatever data collection or data sources will be available. And rather separate from that, we have the data usage. And I just kept those two boxes because data usage can be population analytics, like where are the focus of infections of some disease, or what kind of, what geographical location, or what social group has more prevalence of this or that. So that's population analytics. And there's also surveillance in the sense of tracking the disease evolution. Like if there is a case of reinfection, then someone should be notified, or the patient should be alerted whenever this is some environmental or some personal variable changes. So there's two types of data use, or two major types of data usage I would propose. One is aggregate data, so analytics. The other one is quick or prompt reactions, real-time reactions, and I would call that surveillance for now. But this is overall the pattern for our architecture. We'll detail this in the session today. That's the architecture part. So for scoping, and this is the one that maybe we could do later, but I think it made sense to start now to trigger some thoughts. As I mentioned, patient versus population. So we can have patient-specific case reporting. So things based on focus on the patient, even if the analytics there are done on population analysis, but the data, the data is acquired for the patient, and it would be the intent that you can still follow up on each patient. That's one thing. So case reporting for diabetes could be not only for providing population analysis, but could also be for helping somehow through the process that that someone gets more detail or more well-guided information about the patient's this specific patient's condition or evolution. So we can have a more patient-focused purpose or a more population. Population is just analytics. It's just, you know, on the map, where are the spots of infection, or on the map, which region has more prevalence or has more incidence of this pulmonary disease, or which age group has more cardiac complications after surgery, whatever. So this will be, these are the two splits. These are the two types of purposes that we can slice this in. The other thing is lifelong versus time window. It's not really an important decision. It's not really an influential decision, because what is expected to be time-bound can always become lifelong, or sometimes, sadly, what is expected to be lifelong can just be actually very, very time-bound, whether the patient gets better or the patient does not, gets much, much worse. So that's also another variable that we might want to include, just to trigger some scoping discussion. The other dimension, I would say, is focused, case reporting gets focused on a condition or on a specific aspect. For example, we can have HIV specific case reporting, or we can have HIV antiretroviral treatment specific case reporting. So we can have something very focused on a condition or even on a treatment, versus comprehensive, which starts being like treatments and the condition and associated conditions. So that's also something that influences the design of the system. How focused do we want to be, and how comprehensive do we want to be? Just a quick remark on this, because of course the obvious consequence is that this is the key factor for determining what kind of data do we acquire. And the attention point is for the scope creepiness factor. If we start something that is just for COVID treatment or COVID infection follow-up, next time, you know, you're following up on the reinfection, and next thing next time you look at this, you see that, okay, now we have to handle the vaccination, and now we have to manage the vaccination certificates or the immunization certificates. So it's rather important that the scope is bound, or is rather well bound or defined somehow, so that you take precautions against scope creepiness. The other thing that might be important in the design is facility specific or nationwide and global. This doesn't really affect the, or should not really affect the clinical part of the design, but it has a huge influence, because if you're doing something for facility specific, first of all, you control the data inputs and outputs. You control what data you need, because you are in control of who is sitting in the room to decide what data is necessary. You control the terminologies. You control what purposes do we want to give to the data. You kind of control the scope. If it's a nationwide, you control the terminologies. You can control the design, but you really don't have that much control anymore about the rollout and implementation. So you don't know how good your data is going to be, or what you need to do to maintain the data quality throughout the case reporting system. And if it's global, it's of course much harder to keep things under control. So your constraints and your focus will slightly change. If you do something global, you have to necessarily be more aware, or more how do you say? I don't want to use the word receptive, but yeah, the system has to be more supportive of the variation that will happen between countries. For example, between regulations, not only about what data is necessary, definitely terminologies, but can I use this data? Well, in that country, I cannot use that data like that. I have to, or the data means something different in one country and the other. So depends on where you are. If it's a facility specific, that's really easy compared to a global case reporting. So with this, I would have a first sip of my glass of water, and I would like to ask if someone has ideas based on these dimensions, based on these things, and some examples I gave: pregnancy, diabetes, HIV, some cancer follow-up. Anyone has any current challenges, any ideas for this? I would like to hear them now, so that we, first of all, we start engaging a bit, and then it's good that we can use that example whenever we revisit the technical parts. Any thoughts? Any ideas? Any requests? Any things? No hands raised.
I want to throw them in the Google Doc. I can read them out loud too, if that's easier.
Osama, CDS hooks, that's good. Remind me when we go to the right part of my diagram. So on the, I forgot the name already, the data usage. Remind me if I don't mention CDS hooks, remind me to do so, if that's okay with you. Babacar, I think you are asking about translations. What do you mean? Sorry. Can I ask what you mean with the translations? You can type or you can talk.
Hello? Is that the question for me?
No, Babacar, I think Babacar had a question about the translation.
My understanding is he's interested in having French sessions, as well as understanding if FHIR supports translation.
Okay, so it's translation of the webinar itself, not of the
webinar itself, and also if FHIR supports translation.
I was hoping it were so we can handle both. So we can have some sort of the same content put in our backlog for things that to do in different languages. French is on the list, so we could do something in French. About the translation, there is currently some discussion on how to do multilingual data capture. The whole, or multilingual things, because it's not only about data capture, there are several things in FHIR that we could need to do multilingual, but there is no solid guidance at this moment, so I can advance that. It's on the to-do list. So I guess both the translation of the session is on the backlog and the translation of the content. Well, the answer is the same. So it's something that we can look into. We are eventually taking some effort into, but it's not, there's no solid guidance at this moment, or there's nothing solid at this moment. Anything else besides CDS hooks and besides the translation, the webinar translations and the content translations? Just because I need some water. If not, let's advance to the FHIR bit. Can I have a quick show of hands, if I can put it like that? If someone has not been present or watched the videos from the previous sessions, is there someone in this session that hasn't seen the previous FHIR webinars? Just a +1 on the, put the +1 on the chat if you have not seen those videos or if you did not join those sessions. It's not a problem. It's just for me to be aware of that. So yeah, Lisa hasn't seen it. It's good. Thank you. Nadia, thank you. It's okay. So some of us have not seen those sessions. The reason I ask is, oh, and it's been a while. Thanks, Daniel. I will go through the key parts of FHIR, but like in the other sessions, be aware that this is not a FHIR course. So once you start practicing with FHIR, it will all come back to you. So I'm just going to give a refresher on the refresher. So if you don't have all the details, and if you want to stop me and say, hey, how does that work? Please feel free to stop me now or to intervene now. But be aware that you don't have to follow. I mean, you have to follow you should follow the things that I will be saying because they are pretty superficial. But if you have more technical curiosity, that's okay, and that's the point. And that's okay because both this course and even the other ones, which are a bit more in depth, they were not supposed to be a full in-depth training of FHIR. So, but you should be able to understand what I'm going to present now. And if it's not clear, it's not because you're not prepared, it's because I am failing to send a message. So I'm going to try to synthesize things in a way that it's understandable for first timers. So let me know if it's not clear. So in FHIR, I will be talking about now FHIR resources, data types, how to use terminologies, what is a profile, and I will go a bit more in depth than I was before in FHIR operations. What are capability statements and how to use REST and documents. For example, REST and documents was something that was very briefly discussed in the other one, but it becomes a bit more important now. And I will briefly touch the FHIR implementation guide development process, where we see the logical model, which is actually the thing that I was pointing in the architecture diagram, like that's how we can work. So I will be touching these topics just in a way that we can follow the process for arriving at the case reporting solution. So this is a simple representation of what is FHIR about. FHIR is a data exchange standard, and as such, it pretty much starts, or the most starting point is about elements and data types. So what data elements can I exchange? What data types do I have? So for example, if I want to send the patient name, well, okay, then I have to have a name, and the data type, is it a string or is it a set of strings, or is it a structured set of strings? So that's what FHIR is about, and all of those come into resources. So FHIR has a couple of resources, 100 and something, where we define the key data exchange blocks: patient, condition, observation, medication request, device usage. So we have these things that represent fundamental objects of data exchange, and that is pretty much the core of everything. So whenever we talk about let's design our case reporting system, you'll see that one of the focal points is what data are we talking about, and that's about this. It's about the data models, so resources that contain elements, and those elements have a data type. That can be on the physical level. I'm now reporting to the matrix that I showed, the Zachman framework, where we have this on the physical level, but we can also have the logical models for data. So but pretty much this is the starting point. But FHIR also has very good support for terminologies. There's also a webinar, one of our webinar sessions on terminologies. So if you want to see more details on how greatly FHIR does support terminologies, you can always watch that. But basically it comes down to some elements that we use in FHIR, they are bound by a value set. So you can say patient gender is bound by this value set, And depends, so FHIR has very good support for that, depends on how we implement this or how the FHIR standard is designed. You can say these are the only genders that are accepted, or these are just some genders, you can do something else. So in the case of patient gender, for example, we have a fixed value set, so you can only use those genders. If you want to put a social gender, or a personal gender identification, that is not the same data element. That's another data element, and FHIR also helps us find out how to put those different our own elements into a specification. So we start with this, and then from this we have how to access that data. So how do we exchange that data? It's not only about the data format, but how do we access the data? And then we talk about, well, we can just get the FHIR resources, that's easy, or we can do some searches, or we can do some bulk data, like lots of data at once, or we can do some operations to manipulate the data. So that's about the access to the data. There's some physical layer considerations in FHIR and specifications in FHIR, like documents, REST API, messages. There is a GraphQL implementation. There's SOAP services. Those are, I haven't focused at all on those, but there is also, let's say, some technical specification on how to use the data. And an interesting thing that we are using is the implementation support, and so models and mapping and implementation support. So the implementation support is about how do we make our specifications in a way that we can easily validate them, or we can easily inherit specifications from other systems, because we don't want to redo the work that someone else has already done. So there is some, FHIR has a very good or very comprehensive approach, not only to the core part, which is what's the data that we are exchanging. So it's not just about the XML or JSON format, it's about how do we put this in practice. And we are going to explore that a lot during this session and all the other sessions. On the core of FHIR, we have the resource, as I mentioned before. So we have the FHIR resource. I'm just taking the patient as a resource here, as an example here. In the FHIR specification, actually, let me see if I can show this to you. Should be able to show this to you. Where is, yeah. So if I go to the FHIR specification, which is always in the same place, hl7.org/FHIR. For those of you who did not join, you can always browse through the links. There's lots of information there. But if I go through one resource, and for those of you who don't remember it or haven't seen it, the easiest thing, and I do it all the time, is just type here the name of the resource, that if I know the resource exists, and I go to the resource, FHIR does provide a scope. Where is this resource used, or what does it mean? Basically, if I want to use something, this is the purpose, what it means, and then the content. So this is the definition of the data structure. And then we see that the patient has an ID, or has 0 to many identifiers. So a patient can be identified by his passport number, his social security number, his national ID number, his hospital ID number. So this is the identifier of the patient, and 0 to many. That's what FHIR starts by establishing. And FHIR doesn't make any final assertions of this is what it has to be. No, FHIR says this works, or this is expected to work in 80%, like roughly, it's a rule of thumb. This is expected to work correctly and out of the box in most of the cases. So the other 20% of the implementation, or sorry, of the implementation effort will be like social gender. It's not here. We only have the gender, which is male, female, other, and unknown. If we need to do something else, we have to figure out. But at least with this, we should have a very good starting point. And it's always the purpose of FHIR to make sure that the basic resources, so the core resources, they answer 80% of the needs, or the most common needs that are out there. So things like patient has an identifier, has a status, so active or not. It has a name, and it has a contact, like a telecommunication contact, gender, birth date, whether the patient is deceased and which time, and has an address and a marital status, etc. So these are things that have been considered to be relevant for the FHIR patient resource. Now, there's a whole lot of discussions around this. So before this reaches the state, there's lots of discussions by the HL7 working groups, but this is what we see is the result of that. So lots of people that have been implementing or thinking about this, they have designed this. So it's a collection of good practices on how we should do this. So we don't store the patient age, we store the patient birth date for obvious reasons. We store a photo, but there can be several photos, so it's 0 to many. We store the languages in which the communication wants to be or can be communicated with. So then if we think that this is important, then it's a 0 to many. So this is the resource. The data types, we have them here. So if I see identifier is of type identifier, okay, I'll go there in a second, but the active is a Boolean. That's simple. And FHIR does have a lot of, or a rather rich definition of those data types, or a very formal definition of those data types, and they are in this link. I just put a link to the build.fhir.org. I'll get there in a second. So there's different versions of FHIR. This one is the current development version. It's not the officially published one. It's the one that is expected to be officially published when everything is frozen, and then we start a new cycle. But yeah, so we have the data types like date time or date, data types like Boolean, the one I mentioned, data types like string, okay, and then we have subtypes. So a string is, I think, up to 1 megabyte of characters, but code is a special type of string. It's just normally it should be a much smaller string than 1 megabyte. The code is just a couple of characters. Or we have numbers, we have integers, and we have unsigned or positive numbers. We have URIs, which can be URLs or OIDs or UIDs. We have the canonical data type, special type of URL for FHIR. We have base 64 binary, which is just a string, but is supposed to contain some binary encoded content. So these are the primitive types. We also have other data types or more complex data types. Just to draw your attention to one thing that is really annoying if as long as you don't get used to it. At least for me it was I think it's common practice. The primitive types, they start with a lowercase. The general purpose data types or the complex data types, they start with an uppercase. And let me actually click the link on the data types. Everything in FHIR can be navigated. So if I go here, I want to see, for example, the identifier. What does the identifier data type mean? That's the one I had in the patient. I click here and I say, okay, identifier is actually consisting of several attributes, and this is a use, which is a code. So code is a lowercase, so I can see, okay, this is just going to be one data element. It's a type. There's also a type, and the type is 0 to 1. So type is a codable concept. Codable concept, I look here, is a uppercase. So I'm pretty sure that if I click on codable concept, and I will do this, it will pretty much be in another. Yeah, so there's another structure behind it. And then there's the coding and the text. And if I click here, I would have more details. And actually, this is how it looks like. So in JSON, this is how it looks like. There is something which is a codable concept that contains the coding, as you see. And the coding, if I click here, it will contain a system and a code and a display. Actually, I can just open it there. System version code display, as you selected, all of them are optional. So this is how it looks like. So we are defining the data types. Now, escaping all that technical detail, going back to our slides, this is that's the key point about FHIR resources and data types. We have a lot of data types. One important thing is that everything in FHIR can be extended and constrained. So if I see, for example, that I need to add a social gender to a patient, there is a way to do this in FHIR. There is a technical way to do this in FHIR. If I need to change my string not to be 1 megabyte, but if I want my string to be only 256 characters for whatever reason I want, I can make my own special flavor of a string. I can add constraints here. And this is how they look like. So if I look at the patient, actually this is the thing that I was just showing through the specification. So if I have a patient identifier has a use, type, system, value, period. They're all optional. So here I'm using the type and the system and the value. So those are there. But the type is a codable concept. So if I go to the type, I'm just opening an object, and the codable concept has a coding and a text. In this case, I'm just using the coding. And if I have the coding, if I want to see the coding is system version code display and user selected. And I just use system code and display. This is how it looks like, the FHIR data type definitions. The same thing with human name, which we have in FHIR. We have defined the data type for human name, which is in this case very simple, or we just use a simple part of this, the family name and the given name. So this is John Doe. He has one family name, which is Doe, and just one given name, which is John. So this is how it looks like, and this is the physical modeling of the data. Besides this, and feel free to jump in with anything that you find is unclear. There's lots of resources in FHIR. Patient, medication, as I said, medication, device, all those things exist. There are special resource types, and some of them are going to be important for us. They are usually used for the, if I go back to the other diagram, to this diagram, so these are the, let's say, the clinical resources, but there are other resources like value set code system. There are resources from Epic. There are other resources for these side parts of FHIR that support it. So they are special purpose or special resources. This is about capability statements. Structure definitions is how to define resources. Implementation guide is something that we use in the specification. Search parameters, it's not about the content, it's about how to search that. So there's lots of resources that are still FHIR resources, still follow the same methodology, but they have a different purpose. So it's not really for clinical exchange, it's more for supporting that. So if I want to make a terminology constraint on the patient resource, I have to use something else. And typically that will be a value set and maybe a code system. And those are also FHIR resources. And if I want to put all of that together in an implementation guide, well, implementation guide is a FHIR resource. And if I want to do that, and to have the to do some mapping there, then I can use a structure map, which is also a FHIR resource. And if I want to do all of that and make an example of that, I use an example scenario, which is also a FHIR resource. So this is how FHIR works. Everything becomes computable. So the computers can process that, which makes it much easier for us to have our tooling automated. And you will see today some good consequences of that. I look forward at any time. I'm looking at the chat. I don't know if you can see my chat. Normally Zoom doesn't show the chat, not to bother you with this, but I'm paying some attention to the chat in case someone wants to pop up any question and ask any question about how FHIR should or how they have any questions for FHIR, that we should answer those questions on FHIR, or we should discuss some things on FHIR. So one additional thing that we have briefly mentioned before, and it's going to be relevant for today, is the exchange paradigms of FHIR. So how do we exchange all the data that we've seen in that simple JSON file there? How do we exchange that data? Sorry. So we have different ways of exchanging that. The basic thing is to have some REST exchange, some RESTful exchange, which is just some web services, and it's defined in FHIR how to do that. So FHIR builds upon technologies like JSON, like REST. So FHIR is just a healthcare layer of data exchange, but it does not reinvent things like REST or JSON or XML. It just relies on those technologies, and that will be the basic thing. So basically, REST, for those of you less technical or less aware, REST is just, I have a server and I'm going to ask for the server, give me this patient, or give me the patients that have this name, or give me the patients that have this date of birth. That is a RESTful interaction. The first one was a simple one. The two other ones were just searches, but they are still RESTful searches. However, in healthcare, this has not been the approach. Many of our approaches have been about documents and messages. I'll start with messages. Messages are related or are equivalent to what we had in HL7 version 2. In HL7 version 2, we use messages, and messages means roughly that one party talks to another predetermined party, like when you send an envelope through the mail, you send this to someone, and you have some expectations of what is the outcome of that interaction. So Messages are very often used in lab systems and this kind of, so yeah, especially let me give the laboratory example, because there it's about, you know exactly where the message is going. It's going from the lab, let's say the system that receives that brokers the lab messages, sends a message to the machine like this has to be done, or to the work list. I think a similar thing can be seen on the radiology information systems, where we say this needs to happen. This is going to be the procedure for this patient. So messages are. I'm trying to see if I'm explaining it well. Please raise the hand or let me know if not. Messages are one-to-one or point-to-point communications where you say this is what I'm telling you, and there is some expectation of what is happening with that. So if you see the message as, for example, an order to perform a lab procedure, a lab test, then that message is from the requester to the filler and say this test for this patient needs to be executed. That's it. So it's a one-to-one, and there's one additional consequence. If you send two messages, you're basically making two requests, so you would actually expect things to be done twice. That's something. It's a mechanism to differentiate messages from documents that for me it works well. Whereas for documents are more on the publish and subscribe approach. So a document infrastructure like we have in IHE, CDA, and XDS infrastructures, you send out, you publish out a document and you say, this is the current medication for this patient, or this is what the patient's treatments are currently about. And implicit there is not a request for someone specific to do something. It's more, this is broadcast, and now we expect from any workflow design perspectives, we expect someone to pick this up. So documents, they have not a point-to-point, they're like a broadcasting, and there is also not a very strict expectation, or by default, there's not a strict expectation of what do you expect, what the issuer of the document expects to happen. The issuer of the document says, this is my information. It's not up to me to know what is going to be sent later. For example, we could have the same thing in a lab result, in a lab report. So after the machine is done with the test, the machine is supposed to talk one-to-one to the lab system, but then the lab system can say, I don't know in which hospital the patient is now, so I'm just going to publish out a document that says this is the results for this patient, and someone else can pick it up. Same thing with the prescription. There's with the medication prescription, you can say this prescription goes to this pharmacy, that's easy, or you can say this patient has this ongoing prescription. Any pharmacy can now pick it up and act on it. So those are the two different ways of working, and they are related somehow to the so they use the same resources. They can be somehow related to REST, but the way of working is rather different because you have different expectations, and REST is just resource by resource. Messages and documents, they are just sets of resources. And actually, I think the next slide is about that. Yeah, next two slides. So REST is the most common approach. Is what we start with. It's most of what we are doing is the REST approach, and it comes down to fundamental interactions like get. So that's the verb to read. So get me this patient. Get me the patient that has this date of birth. And the response is always one resource. It's a patient or a bundle of resources or an operation outcome. If something goes wrong, there's an operation outcome. And we can say the get me the patient, or we can also say I can post the patient. So I can say to the server, please store this, or here's an update on the server, or please delete this. So that's very atomic communication on a resource level. More interesting for us is the use of documents. Documents is a construct that we have in FHIR, which pretty much puts several FHIR resources together in a specific combination. And the documents in FHIR means a bundle. So bundle is also a type of resource. It's one of those special purpose resources that I just mentioned. Bundle is a type of document. Document is a type of bundle, sorry. And in FHIR, to have a document, we have a bundle where the first entry is a composition resource. And that composition resource, it acts like the table of contents in a document. It points out to the other resources. And it can have a signature, it can have a provenance, because when you say when you, for example, when you publish a prescription, a medication prescription, you say, this is the current prescription. I'm signing it off, and from now, this is the thing. Maybe a better example of a document in FHIR is a discharge letter. So when you have a discharge letter, someone is signing off that as of today, these are the things that are known about this patient. Someone is really signing that off. And if something changes, if the patient has an accident when leaving the hospital or something, that is not necessarily updated. Maybe the server already has the information, but if you want to update the discharge letter, you have to get another signature from the doctor, because now you need the doctor to validate if maybe the medication that the patient got for the pain of the fall is not consistent with the medication that he had before. So there is always a final snapshot validation step before issuing a document, or there usually is one. Documents are used for persistence of data. So when you make a document, you say, this is the current status known, doesn't change anymore, even if the underlying data could change because it evolves, but this document stays as is, it's persistent. It's also used for seeing who can change that and who can maintain that. It is authenticated, there's some signature, and so there's also some integrity assertion about this. It also comes with a context, and it has a structure that facilitates human readability. So it's, if I want to see what the discharge letter can contain, then I expect these, some of these resources in a document. So document is a snapshot of set of information. It's very important for us or it can be depending on the architecture, on the case reporting. So looking at those things and starting with that, just wanted to have a brief recap of the, so we'll do this later, we'll check this later, but in FHIR we have specifications. So we take all of that and we make specifications. So there is the whole FHIR profiling and the implementation guide videos. You can always watch them. But in short, what we are doing is we add constraints. So we say, in this case, I don't want the patient gender to be filled in at all, or I want the patient name to be mandatory, or I want at least one identifier to be mandatory. So those are extensions and constraints that we do on our profiles. And the key thing for us is that we can add specifications on top of specifications. So for us, here's one example, and we'll see how this works. We have the Firebase Specifications. From this, we can have standard constraints. So SDC is one thing that we are going to look into today, is one additional specification that builds on FHIR, but it's not the FHIR core, but it's an additional layer on top of FHIR that says, if you want to capture data, this is a standard way of doing this, and there's a lot of power in doing that in a standard way. Then we can say, okay, then this is good. It's very useful for case reporting. Then let's make a case reporting layer out of this. And then we have the case reporting fundaments. And on top of that, we can say, that's very interesting for case reporting. Let's refine this for example, for HIV or for chronic disease specifications. So we can add layer. And on top of this, we can have our own project or our own language. So we can add layers on top of layers. This is very important for us, because what we'll be doing today, now in the next part, which is the architecture, we are going to be looking into exactly how to put these use cases. So also as a very short note, what we do when we make our case reporting solution design is we define the use cases. So we have that in our webinar for FHIR implementation guides, but it's pretty much, we define the use cases. And you remember when I mentioned the fact that depends on if you're on a national scope or in a project or on a facility specific scope. Very simple or very complicated. You define the scope by defining some use cases, what do you want to support or what you don't want to support. Depends on your approach, but my advice is always make sure that if things are explicitly not supported, that you really say, hey, we are never going to support this. If you want this to be supported, please tell us now. Otherwise, this will become a scope creep. You have those discussions in the first steps, defining the scope, and then you define the data, and then you find the functional view of the data, logical models, or you define the technical data, so the FHIR profiles, we'll get there, and then you do some terminology on this. It's pretty much this. The case reporting has a few more technical things, but the way of working is always the same. In all these layers, you always do the same thing. FHIR, so you want to have a FHIR implementation, so you define what's your scope is, what the use cases are. From this, you define what data you want. Normally, I advise to do this functionally so that you have a good understanding between the functional and management people. So the non-technical people can agree on what the data means, and only then hand it over to the technical people or the standards people. And then you start designing your technical system. Now, while I get some more water, we are about to start the case reporting architecture. I don't know if we should have a short break now, because we are halfway through the session. Rhonda, what do you think?
That sounds like, I think that's a good idea. Do you want to do maybe 5 minutes for everyone to go get coffee, take a quick rest break? We'll be back at the top of the hour.
Yep. Then we
All right.
Yeah. See you in 5 minutes.
All right, perfect. See everyone in 5 minutes. If you have questions or anything in the meantime, please go ahead and throw them in chat, throw them in the Google Doc.
And if you have
Here.
an interesting thing happening on your side, like, oh, we want to do this for this disease, or we want to follow up on diabetes, or we want to follow up on case loss, whatever. No matter how crazy the scope might seem or unrelated this might seem, please bring it up on the Google Doc or on the chat. My clock says we're back.
You're in fact back.
Okay, so let's continue.
Okay.
Yeah. So so let's look into the architecture of this. So those are the technical fundamentals of FHIR, which we will now apply, or we will see how they apply. So let's look into case reporting from an architecture perspective. So just looking at what do we want to solve with case reporting? Do we want to observe how a patient's condition evolves, or how we want to track chronic or epidemic diseases, or do we want to capture short-term episodes, for example, pregnancy episodes? This is something that dictates our scope. But regardless of that, or with starting from that as a scoping decision, case reporting kind of architecture fundamentals, as I said, will follow or could follow this type of architecture. Let's go a bit into the detail here. When we talk about data sourcing or existing data or data procurement, we can talk about systems that have that are working, so EHRs, systems that have data ongoing, like a hospital has data, and we might want to do case reporting based on hospital data. So, for example, if we have, or clinics, if we have HIV case reporting, we might want to say, let's just get the medication data that is given for these patients from the hospital or from the pharmacies themselves. We don't have to repeat anything or to re-enter any data. We just have the possibility to go there and get the data. Or we can have some legacy or existing data. So we can say, well, we don't have really an EHR working, but we have a regular extract of data from different sources, like there's a governmental decision that mandates that this kind of data is reported by every hospital every day or every month. So, for example, for COVID, this became quite common, and for many diseases, there's mandatory report, there's standardized reports. So we can have the data, even if we don't have access to the EHRs behind it, we can have some standard data like CSV files, XML files. So there could be some data. So assuming that data it could be, and these are just ideas to help guide in the design. We can have episode data, so we can have, like, this is the pregnancy system. So let's go into the OBGYN systems, or this is cancer treatment data. So let's go into the oncology treatment systems. So we can have data in different systems for the episodes. For each, for the pregnancy, it could be one visit to the hospital, and then we just go into that hospital admission system or the OBGYN system and see, get me the data patient by patient. And then you count the visits or you count the occurrences, etc. So that would be on an episode level. You might have the possibility to get all the data for one patient. So that's more longitudinal. I'm calling it longitudinal case data. You can say, get me everything about this patient, because maybe the patient has a dossier about cancer or about diabetes in a given facility. So you can have some longitudinal case data. If you don't have it, maybe you can collect it from different episode data, and we can stack data. We are going to check that in the data pool side. We can have legacy data, so you can have like a big CSV file of data, or we can have some mandatory reporting that was issued last year, or something that you still want to acquire for population analysis. Or also interesting here, you can have some other data, for example, master data. You can have for example, the list of HIV ARV treatments. You can have those things defined. So that is not patient data, that is master data. So you can have the list of what treatments have been established for different stages of the disease, and you can have that data as well. So all of that data is data that you can procure. Step one. Step two is, that's very interesting, but how do we get that data in a way that we can do it? So first of all, the ideal universe is that you have that those systems, they talk FHIR. If those systems talk FHIR, you just use the FHIR interface to put them in a data pool. That will be the ideal thing. if those systems speak a different language, you can have some sort of a data import procedure. You can have a mapping system that says, oh, this is the CDA format or the XML format. Let's map this into a FHIR format, or these are the CSV files. Then let's map that into FHIR. So we can do that. Or in many cases, you just don't have data and you have to say, from now on, the nurses should acquire this additional information or should capture this additional information upon every visit, because that's what we did for COVID. So we needed to get people to collect their data in a FHIR format. So we said, here's a way of capturing that data in a structured format for COVID, because we know that the HRs don't have COVID data, because this was 2020, early 2020. We know that no one has this in production. We know that the data is also fully defined, but that doesn't matter. We really need to have the data in a structured format, otherwise we are not going to be able to track the disease. So we have a thing called structured data capture. This is the whole thing with FHIR tooling that I will mention in a second, with all the profiles and the layers. We'll check that, but we have a way to facilitate entry of data in a structured format, regardless if you have existing data, in which case you can do the data import, or if you have existing interfaces. If you don't have it, if you just have data that has to be captured anew, so data that you have to ask everyone from now on, please capture this, you have mechanisms for that. And out of this, you get FHIR data, or you can get FHIR data. This session is about FHIR, so we are assuming that out of this, you will get FHIR resources. So you'll put this in a data pool. So you put the data objects in a data pool. So we have different types of resources. We'll see how that looks like, but you have patients and observations and conditions and medications. You have a pool of data, of connected data objects in the data pool. Out of which, a couple of things that you might want to do on the data, again, depending on your scope and what you want to use the data for, is, for example, the identification. If the purpose is population analysis, you really don't want to have any personally identifiable data in the data pool, or at least when you get data out of this, you have to make sure it's cleansed out of any personally identifiable data. However, you might, yeah.
Got a question from Alvin.
Yeah.
Will there now be 2 copies of the data pose in the EHR first column, data objects third column?
Yes. There will be, well, so see the EHR as someone else's system that we want to get the data into, we want to get the data out of, and the data pool is our case reporting system that contains the data. So it's not once, so let's say that you have nationwide, you have 300 clinics and 20 hospitals that provide the data. You might still want to have one data pool to collect all that data. So yes, and you don't want one system to replace the other. So the idea is to acquire data. What happens after you capture the data? That's, well, in the HR, that's not our problem, because we are looking at the data pool for reporting. So we just want to capture that data. So see this as, for example, HIV or COVID cases. The governments, they have data pools for the accumulated case reports for COVID and infections, etc. What happens until that point, or whether data is retained or not in the original systems, at the level of government reports, it doesn't matter anymore. We have the data, we can do what we want with it. So the identification is one thing that we might want to do on the data. The other thing is data reconciliation. I just mentioned this because it's important as we design the systems. Suppose that the patient is visiting, and this is very common in HIV, for example, patient visits different clinics, different facilities. How can we make sure that the patient who has an identity, well, in one clinic he has given the license, the driver's license number, in the other one he has the insurance number. So it's not even the same identifier, and the name has a very common name. So if you go to Portugal and there's a guy called Jose Costa, then you don't really know who that person is. Can be one of many, many people. So if you have this kind of need, then you might be looking at data reconciliation, for example, patient matching, or you might see that the person has contaminated the partner, but and you have 2 reports, but you don't know if they are related. And so you have one woman and one man they have both been contaminated with any infectious disease, and they come up as two different people. So far, so good. But if each one of them says, I contaminated my partner, then you might have 4 cases until you reconcile them and see, no, there's actually just 2 cases and they are one related to the other. Osama, in which category will consent fall? Let me get that in a second, just after I finish the data reconciliation part. So you have the need for functionally reconciling the data or doing something on the data about patient matching. For example, the same person visit different clinics, but it's actually the same patient. How can you figure it out? There's a whole lot of things to discuss there, but it's one functionality that you might need. And as you can expect, if you have de-identified data, it's very, very hard to reconcile the data. If you no longer know the name of the person, you can no longer guess that they are the same people. So I just wanted to bring this example to see that in the data pool, what happens in the data pool has to be aware of the different needs that you have. So you need privacy and de-identification, sure, but make sure that doesn't step on the need that you have for data reconciliation. Otherwise, you have completely different figures than you would have if you'd done things differently. So this is just one awareness point for that. In which category will consent fall depends on what you are on your legal framework. But let's take HIV, for example. You really don't want to exchange HIV and sexual behavior data out there. You really don't want. So it's going to be very protected data, let's say. Clinically, legally, I think everything applies there. So if you want to see where would consent fall, let me extend the scope a bit more. Because for me, privacy is not about consent. If I tell my hospital, please don't tell anyone that I have tuberculosis, my hospital has the legal right to never mind what I just said, because they have the legal obligation to report that. So let me just talk about data usage permissions. So if I answer your question, in which category will data usage permission fall? I think in each step. So in the data sourcing, when you get the data, you should be aware that of the legal constraints, like, can I get the data? But that's a design decision. So you see, can I use this? Can I extract this data? You have to have some management discussions, like, can I really extract this data? Is there something here that I should dispose of? I should just completely not import. So the design that you do on the data acquisition is important. But also after you have that, let's say that you have a legal permission, you have a legal support for getting the data. You might still have other constraints when you do the data pool. So let's say that the government allows us to, or the legal framework allows us to get data on HIV or COVID to track who is vaccinated or not. You still might have to do that on each of the data uses of the data. So I think it's pretty much everywhere. So where does consent and permission add? Everywhere that you have data going into one place from another place, you have to do this. In fact, if you look at the GDPR, whenever you talk about data, I think they call it data processing, sorry. Data processing can be whenever you store data, whenever you exchange data, whenever you transform data, everything you do with the data. And that's a broader design consideration. You just say, can I do this? Yes or no? That's an interesting, we can go into some interesting details there, but for the sake of time, I will just say, for my perspective, from the moment that you look into, I will get data from the EHR, you are talking about clinical data, so you better be sure about what your legal grounds are. If you have a CSV with de-identified data, maybe you don't have to worry too much because it's already de-identified, so you're more safe, but always check at every point, everything that you're doing that comes with that design consideration. So it's a general thing, it's not something that you do here or there or in each site. So after we have the data pool, then we can make use of the data. And as I mentioned before, we can do population analytics, so just popping dots on a map, or you can do surveillance. I think, Osama, you were asking before, where does CDS hooks fall in? CDS hooks, I think now it's called FHIR subscriptions, it's here, and that's actually what I call surveillance. So you can have a data pool and say, my data usage is not going to do any fancy reports or data exploration. My data usage, I just want to have a trigger that says whenever someone is readmitted for the same condition in a hospital for diabetes or whatever, whenever someone has this event or this trigger, I want to be informed, or I want the doctor to be informed, I want the patient to be informed. That's more of a episode surveillance, or yeah, that's more on the CDS hooks scope. And that is, I think it's now called FHIR subscriptions. There's a whole mechanism for that. So basically, once you have the data, you can say, these are the events that I want to subscribe to. And then the system can actually say, hey, there's one case, or here's one event, or here's another event. So those are the two major types of data usage out of this. And of course, population analytics, you can expect some de-identification, or you can expect not to have identified personal data. If you want to do surveillance, maybe you just want to say, hey, there's one case, hey, there's another case, or you might say, on that house, there has been another case. You can have maybe those different considerations. And again, depends on what you want to do with the data. Do you have the legal justification to do that? Can you do surveillance? Well, depends on your legal framework. Depends if you have a legal ground for that. So the whole privacy thing that applies, and the CDS hooks is about the surveillance thing there. If we have any questions, I'm going to go a bit more into the some more details to see if there's anything missing, because there was 4 slides in there, but I just went through them. So data sourcing is about, when you design a system, you will look at what data is there, what data can I acquire. So actually this hints at the privacy thing. Do I want to capture the whole episode data, or do I want to capture just one single thing? There's EHR data, legacy data, other data, and also important here, when is it acquired? Do you want to acquire this every time the patient goes to the hospital, and then you have to set up something in the system? Or do you just want to say, no, we wait until the end of everything, or we wait every month, and then every month we go back and track the history, or we just go back and do the full history analysis from the last 20 years since the system has been implemented. So those are things that you would consider. What data do you want to have, and when? What is the trigger for you to get that data? On the data pool, normally you have data objects, and a bit more in detail. You have 2 types of data. So data functions is what we've seen. So data processing and reconciliation, you have the identification, and the data objects, they can be FHIR native or not. So you can say, once I get the data in a FHIR format, because we're not talking about FHIR as an exchange format, you can choose to store your data in a FHIR format or in any SQL table database format. It's up to you. The tools that we are now using, we rely on open source tools, and the FHIR ecosystem is very rich, so we tend to use the FHIR-based storage as well. We tend to use Happy, it's because it makes our life much easier than redesigning a database for each case report. And the 2 types of data structure that I would like to mention here is, you can have a case report or a case record. These are the names that I'm provisionally giving them in these discussions or in similar discussions. Case report is, someone said, this is so case report is, this happened today, or this patient has been feeling this. That's one report. Case record is when you stack things, and there is also, so this goes a bit into the reconciliation, there is effort in transforming a case report from a case record. And again, if your data pool, if your source data has case records, fine, bring it in one format, typically a document format. Remember that document is a structured snapshot, so it's perfect for exchanging data in a non-atomic format, but in a snapshot format, like this is what is known about this patient, that's it. You don't have to do any reconciliation because it's everything reconciled there for you. That's more of a case record thing. Or if you have a case report, that's more on an atomic level, but it's still it can still be a lot of resources. And we'll see one example, but you get these FHIR structures, which can be one resource or one set of resources put together. But for me, the split is, one report is one event, or do we get a longitudinal case record? very likely, I would say, you will end up transforming a case report into a case record, because you have different case reports coming from different regions in the country, from different systems, and the data pool is exactly to collect that information and transform that in saying, if I want to follow up just so if I want to follow up the number of events, then it's fine. But if I want to follow up the case for the patient, then I have to build up the longitudinal record. Therefore, I have to build it up. So I have to see that this patient and that patient, they are actually the same. So if these two spots, they're actually about the same patient. So I have to put them together, and then I can analyze the patient's treatment. So just a quick answer on the question on what is Happies underlying database system. It's based on SQL. It supports, I don't remember the name of the database, like one of those ready to use file-based systems, or it supports a proper MySQL database. I think it also supports Postgres database, so it supports all the standard stuff. Most systems, most FHIR servers, they are using SQL structure. There's a couple of servers. I don't know if there's any open source servers that support NoSQL database like MongoDB, etc. There's a couple of those. I don't remember by heart if they are also open source. But our stack, the Happy stack, so our usual stack is based on relational databases. So data acquisition, and this is pretty much where FHIR plays a role. We get data into the target format, so the storage format. Is it, as I mentioned before, is it user entry? So do we ask the patient or the nurse to get the data, or do we get data from the HRs? And if we get the data from the HRs, do we expect to have FHIR interfaces, or do we do a data import from whatever is out there? So those are the considerations that you have to do when defining your architecture. So you might have one path of information, which is, we don't have anything for COVID. We don't have anything, so we just capture everything fresh and that's it. Or you can say for HIV, we have some information that resides on the HRs, like the medication treatments, but we don't have the case indexing thing, and we need some more data elements. So we need to ask the nurses to provide that information. So these can be combined. So you can combine legacy data that you can import with the existing FHIR interfaces if you're lucky to have something, and you can have some structured data capture for new data. So, and the data usage, I'm not going to go into details of this because we will have a session on analytics, a webinar on analytics. You can have dedicated architectures for that. There are some existing specifications in IHE, for example, on how to get data from the pool into analytics. But then there's a whole stack of systems that we can use, and the surveillance and trigger events, that's about FHIR subscriptions or DCDS hooks. So those are the key components. And within those, the data input, so can Happy do patient matching? This is done outside of Happy. So we are actually discussing what is our reference architecture, or if there is a reference architecture that can do FHIR patient mapping based on a FHIR API. So ideally, I would like to have a standard specification for a patient matching API on which we can have our own protocols and calling that API that could do some patient matching. So does not exist in Happy at this moment. So within all of these systems, data is circulating, and data input can be, as I said, the patient episodes, or the full history, or legacy data, or the product data, or the treatment data. And so in terms of FHIR, this is pretty much what I mentioned before. So we can have some CDA or CSV files which we need to import. We can have FHIR resources, or we can have FHIR resources in a bundle, like a document, or, and this is let's begin the fun stuff, the FHIR questionnaire for data acquisition. So I would now smoothly transition to the use of FHIR forms. So for those of us who are making systems that require new data to be acquired, this is one of the key things. And on this specific part, we will have maybe workshops, maybe more dedicated or more in-depth sessions to see how they are used. So I'm going to give an overview of this. There's a lot of knowledge behind this. But if you have to report something like an allergy intolerance and a known condition and an encounter and family member history and the medication status, if you want to say, in my use case, I need to capture whether the patient, so what the patient took in the last few weeks and the consequent allergic reactions to this. I don't know, I cannot make one example of that. Then very easily, this will come up with like 5, 6, 10 resource types that you have to use. And to capturing that information, implementing those complex interfaces, then you are talking about lots of resources that are connected to each other. You can do that, but FHIR has one nice mechanism, which is the questionnaires and questionnaire responses. So I would like to briefly mention that. Suppose that you have this kind of exam, so an OBGYN exam, where you have lots of these questions. If I look at this, if I try to map this into FHIR, and again, I would follow the same process. So I would describe the logical model, so I would describe data from a functional perspective, where all of these things would be, and then I would map this into FHIR resources. But if I do this, there will be a lot of FHIR resources. So for example, this could be, I don't know, an observation. The medication would be maybe some medication statement resources. Operations will be a couple of procedures resources. Allergies will be allergy intolerances. Smoking, yes or no, would be either an observation or a condition if you want to capture the addiction. The examination will be one or no, actually several observations there. So just this thing that looks like a very plain looking sheet of paper, it would correspond to many FHIR resources, so many instances. So you have an observation for the height and an observation for the weight, and another one for the blood pressure, another one for any urine results, and any one about thyroid conditions. I don't know what breast would be, or if it's palpation or any surgeries. I don't know, yeah, any heart conditions, any lungs. Oh yeah, so maybe these are conditions. You'll have many resources. So the file that would correspond to this is very big. And if you just want to capture this always in the same way, FHIR has introduced forms. So actually the questionnaire resource that gives us a very good control over user experience, like how questions are phrased. Like you can say, is this a multiple choice or not? Is it a checkbox or is it text? Is it coded or not coded? So you can do that. And the purpose of the forms in FHIR, so the questionnaires, is that you have a very simple data model that really resembles the data model that you want to have from the origin, and the rest becomes the mapping to FHIR resources. It's not up to the user to worry about. So there is a resource called Questionnaire in FHIR, which has lots of, blah, blah. What matters is that we have items. So we have questionnaires, and each questionnaire has questions. And for each question, we say, what's the text and what's the type? And the type is string or a date. And there's lots of, like, it's a repeated question or not, is it required or not? So there's a couple of other things there. But what matters is we can design how do we want to capture the data. And I'm going back to this. We can say this is a date. I want to acquire the date, not the string, but the date. This is the name. I want to give these characters for the name. I want to get the gestational age also as a date. I want to capture this as a checkbox. So these are things that I want to capture as I'm seeing them. How that maps to FHIR resources, that's another problem. So with that in mind, and knowing that, so the design process here is that we say, okay, for example, the silly example, what pizza toppings would you like? This is a multiple choice question that has maybe a free text thing. So we can model these questionnaires. Let me just go through this. And in FHIR, if we define the questionnaire, like what is your name, and we say this is a string, what is your quest, and this is a string, your favorite color is a string, then we have defined in FHIR a way to get a standard structured response to those questions. So we can say, this is the questions that you shall ask your COVID patients, and this is the structure of the responses that you shall get. So we are now entering the realm of capturing data in a very structured format, in a very strict format, but without having to bother with all the, if it's 1 or 20 conditions or observations. Yeah, each question is related to so each response is related to the question. And FHIR has done this fundamental resource, the questionnaire resource, and the questionnaire response. And FHIR has also additionally added one thing called structured data capture. So structured data capture is a HL7 specification that sits on top of FHIR. You remember the pyramid model that I had there? This is the second level. So FHIR says there is a thing called questionnaire and a thing called questionnaire response. That's it. Now, the HL7 team, acknowledging that this is a very powerful mechanism, say, well, there's a couple of things that we can standardize on top of this. So how can we standardize complex form rendering, like paging behavior, rendering and behavior, paging behavior, color, and how to put the checkbox. Is it a radio button or is it a drop-down? So this more advanced form rendering. Or how do you populate forms? So for example, how do you say if I enter my national number, if there's a chance that the system does some lookup and put my name and date of birth automatically in, how could that be achieved? Or more, very interestingly for us, how do I extract data? So how can I get from this thing, how can I get all the observations without worrying or without making my own custom system? And I think the key point here, and how do I put forms together and how do I make forms adaptive, etc. But these underlined ones are the most important ones. So I think the key point is, now that we capture case data, patient case data, if we can capture this from the nurses, for example, or from the patient themselves, if we can capture them in an easy, accessible format and then worry about the data extraction later, this is very powerful. So we are now in our flow, we are making a very quick path between data that we need to acquire because we do not have the data, so it's data entry, so it's the data acquisition part, and then all the way to get this into the pool in a simple and an expedite manner. So the structured data capture has defined some key features. So how do we make the form look better? How do we enable population of forms, and how do we extract data? So these are the functionality that is supported by structured data capture, by this specification, by this HL7 specification. And it answers questions like, how do you find a form, which for us maybe it's not so relevant, because when you have a case reporting, typically you know what form you have to fill in, but sometimes you might have, in a hospital, you might have thousands, or well, not thousands, but maybe tens of forms, dozens of forms. And how do I get the one that actually matches HIV, or how do I match that? So there is also some possibilities there to search for FHIR questionnaires, FHIR forms. How do I retrieve, what values do I have, can I fill in my form? How do I manage form completion? Like, how do I save and how do I continue? How do I submit a form, and what is the transactions that we put there? How do we complete a form with, like I said, with the patient ID, getting the patient details or previous conditions that are known so that we don't have to retype them? And how do you put forms together, and how do we extract data? So the extraction is actually the thing for us. Now, we will definitely, unless there is no interest, we will definitely have a detailed session or workshops, at least, on this matter of structured data capture and the way to use it in case reports. So on the technology part of this, I just wanted to mention one key driver thing, and this is for me, this is the key point. The fact that we have done, so that FHIR has this additional layer that says, this is how you can render a form, this is how you can procure a form, this is how you can get data from a form. The fact that we have done this in a standard way has allowed us to build standard tools on top of this. And I will just go to this link. So these are the Sdc implementations, so the systems that have said, well, I am going to make a system that is the form filler. So the system that says, I want to enter my data, or I want to design my questionnaire, that's a form designer. Or there is something about the extraction here somewhere, or maybe not. Yeah, it's a form filler as well. So there is all these capabilities are standardized. So lots of people have jumped in and said, oh, I'm going to make my own implementation of this. And I'm just going to show an example. So the fact that we have this standard features. Let me just go back to my screen. For example, this is just one site that has a couple of JavaScript libraries. that allow me to use a questionnaire. Now, I'm going to go very quickly to I'm just going to mention very quickly the context of where we were in the last implementation guide webinar that we had. It was about food allergies. For those of you who might not remember or are interested, we had the food allergies as a silly example of how do I capture food allergies? Well, there's a resource for that, but let's capture the information model in a logical model, etc. We had that. And having that, with one example, etc., we had we made an implementation guide. So what I did just in preparation for this is, if I don't want to bother people with the FHIR resources, or if instead of one resource it would be 10, how difficult would it be to have this with this tool set? And I'm just going to show to you that we have the I just made one form here. This is something I did in a couple of hours. So we had still the food allergy model, okay, and then I just made a questionnaire. So I just made the FHIR questionnaire. So this is sushi for those of you who are not familiar. It's just one way of entering FHIR content. From this file, I created something. I created a JSON file, so a standard FHIR form definition. And what I'm going to do now is just go in here and upload the one that I created. So it was rather easy for me to create one form. And since I created that form in a SDC format, then this is what I get. So don't mind the 3 dots. It's because I could not figure out, I could not fill in the possible values here, and it's still looking for the server, but the server does not exist. So if I say food allergy report, I can have the patient ID, I can have the substance, and that those are values, and the status there, and I have the dates. So this is implemented. So the library is there to render this immediately to me. I did not do any coding for this at all. I just had the questionnaire defined, and immediately I can use one of these tools to render my form. So this is the key advantage for SDC, is that those features are standardized. So there's quite some tooling on top of this, and the key tooling advantages for us are two. Is first of all this rendering that you can immediately, let me see, there's a question, you can immediately render something just by doing this. If I go here and to my specification, and if I change something here, let me see if I do this, but this will take a while, but I can still do it in the background, and if I remember to go back, if we have time, I can still do it. Let me see if I can. Yeah, so it's building. So I just changed from when reported to when was it reported on the recorded date. And if I do that, trust me, and I can verify if time allows, that this will change without me doing any coding. So this means that when we define at the national level, these are the questions that we want to be presented to the user, that's it. You can use any of the existing libraries, and with zero coding, well, just to render the form, you can do this. Of course, there is coding into authentication and to putting this somewhere in a web portal, but the rendering becomes standardized, and that's very powerful for us. Can you point the questionnaire responses to resources at the NLM Value Set Authority Center? I really don't know what is the NLM Value Set Authority Center, Alvin, sorry. There are a couple of examples here. I don't know, maybe they are not. I don't find them. I don't understand if the question is if the yeah, so let me answer the second question, because that one I have. Yeah, the output of the LHC form designer is a FHIR questionnaire resource. No, it's a questionnaire response resource. So oh, sorry, no, never mind. The output of the LHC form designer is a FHIR questionnaire resource. So when we design a form, we design a questionnaire resource. So I can just show to you the questionnaire resource, actually the one I just created. Where is it? It should be here, and it should be on the questionnaire. No, not this one, sorry. Oh yeah, I misnamed it. I should have this here. Yeah, the name is incorrect, I guess. Yeah, Yeah, this is a FHIR questionnaire. So the output of any design, and if I go to the other, where is it? The form builder. Let me see this. Yeah, so the output of this is indeed a questionnaire, a FHIR questionnaire. The output of this tool is a questionnaire response because I'm actually typing in the response. So this will be a questionnaire response. So going to the VSAC thing, I don't know if the form, sorry, if the form builder has already some. No, this will be on the FHIR server. I don't know if there's anything eventually out there. Is it okay if I get back to you offline because I don't know where to find? I'm sure that the National Library has lots. National Library of Medicine has lots of those things. I've seen them, but I have no recollection at this moment of where to find them. Is that okay, Alvin? If I just part that question. So, but thanks for the questions and please keep them coming. So this is one thing that I wanted so this is one of the fundamental aspects, like how easy it is to get one form and to enter it into a tool. This puts the power, or let's say the power of the developers, not in readjusting the form. So if tomorrow we want to adapt the form by having one additional value or one additional field, or one additional value in a drop-down, or one different format, then we do it in a standard way, and this propagates through the tools. This is very powerful because then we can acquire data and really facilitating the work of developers to implement this. The other big advantage is the fact that you now have data extraction. So let me just go into data extraction. There are three mechanisms, and we will technically explore them later, but in Sdc, so in that additional layer on top of FHIR, we define three ways of getting data. From a questionnaire, you can get data from an observation, so it's called observation-based. It's defined in the Sdc, for which you have the link in the presentation that you will receive. So you can say, I just care about observations, so here's my form, and here's how it maps to observation fields. That's easy. It's very limited. It just produces observations, but for very simple cases, it could work. Definition-based extraction, it's when you say, this is my form, this is what the data, so this is the formal definition of the data, and if that formal definition maps to one resource, so if you say this field in my form maps to patient.gender, then there is a way to get that data directly into patient. And when I say there is a way, I mean there is an automated way so that you don't have to do any coding for this. And I'm just going to show an example. Or you can have a structure map based extraction, which is the one that is more complicated, and I'll show how complicated this gets. But the fact that it's standardized, it means that we have standard tools, and the fact that we have standard tools and there's a standard operation called extract. You remember when I mentioned FHIR that there's a thing called operations. You can have a thing called extract operation, and you can get data out of a questionnaire with one single click. And I can actually show one example of that, just one quick demo. So structure map extraction, which is the one that we are using in the current implementations. So we are using the definition based and the structure map. The one that I'm focusing more now is the structure map. It uses yet another part of the FHIR standard, which is the FHIR mapping language, and it can very easily get really complex. We are still working on making it much more accessible, but let me just show you one example. If my computer responds. Yeah. So this is just one example that I had at hand. I just found this one. Just minimize this. So let's say that for diabetes risk, we want to see what's the diabetes risk of a patient. Well, there's a standard, I think it's a Danish recommendation that became kind of quickly global recommendation, like this is the patient age and the body mass index and the waist circumference and the physical activity. And if you answer all these questions, you get a score. And out of this score, you can say what is the risk of that patient developing diabetes within 10 years. And it can say this is low until very high. So suppose that we have that form, and suppose that at the end what we want is just an observation. Of course, you will want the observation and the patient at least, but suppose that you want the observation result because the patient ID is there. If you do that, so you can say that, well, if I want the observation, I want to have a SNOMED code for the observation. Okay, it's there, it goes into observation code. And I want to have this as a category of observation, which is a risk. It's not a clinical realization, it's just a calculation of a risk. That's fine. And oh, actually this is reversed. So, and the time of the observation is issued, and the current patient is a subject, and the actual risk. So the observation doesn't need to care about all of those things, because then it will get much more complex. And then let's say we have the total risk score of the patient, and we just want to put it in the value of the observation. So this is visual representation of that mapping. And this text here is how FHIR does it. So you can see, like we're talking about 30 lines of text to have this mapping. The fun thing here is that all this mapping here is just pretty much about these 2 or 3 arrows. So it's about this arrow and this arrow, and that's pretty much it. So 2 arrows here, just these 2 lines, they mean this. So the mapping gets very complicated in a way that it's possible for a human to do it, but it's quite tedious and it gets very long. So it's lots of moving parts, lots of code that we have to do. So we are working to make that a little better and to represent it in a kind of a civilized way, which is like some sort of diagrams. All the tools are evolving because we now have a standard layer like the SDC. So I just wanted to show this is how the mapping looks for this kind of very simple mapping. Now imagine how this would look for an HIV mapping, which has the patient information for different identifiers and the residence of the patient and the risk factors and the diagnosis of the HIV, when was it and what test they did, and the CD4 test and the viral load tests. Imagine the mapping about this. And as we've seen before, how that mapping would look if we want to put all these resources then wrapped in a bundle of type document. So that would be a very complicated mapping. It is done, it's doable, some people are doing this, but it requires a lot of effort of mapping. So mapping is a complicated thing, but the good thing about this is that, or before we go to the implementation, if we'll have to see, we have 12 minutes. I just wanted to show this just as a teaser. Suppose that we have, so this is just a server that I just set up. For example, this is just a demo. If we have a question that says, well, this is in German, and if I have F, and if I have some mapping language here, so don't mind the picture, but the mapping is like this, then I can click the extract button and I can get this. So well, that's not actually working. I think the mapping is not working. Or if I go to the diabetes questionnaire, I can get this from an observation, and I don't have any values. So all of this is happening in the background, and it's just 2 or 3 server operations. So one is getting the questionnaire and rendering it immediately. So this is the kind of tooling that we are looking for to make your lives easier when you implement this part of the data acquisition. As you see, the questionnaire, I did not mention that, sorry. It's rather important as well. The questionnaire has features like how can I calculate some fields based on the other fields of the form. So if I go here and say, well, the person has a higher body mass index and has this, so then this gets calculated differently. So the calculation is done within the form, and there is, if I change the scoring or if I change the text, I don't have to do any coding. I just have to define the questionnaire, and this is automatically calculated. And if I do this, I have my mapping, and if I have my mapping, and if I click extract, then I have my observations. So it's not for the diabetes risk. It's just to see that if I go back to the architecture and see this path of acquiring data, capturing this, putting it in a data pool as FHIR resources, this is immensely facilitated by having FHIR as a standard for data exchange and by having standard FHIR tooling, which is what we are working on. And that's the community that we are trying to facilitate and stimulate. So I just wanted to use this as a teaser. And now to wrap up, I guess, oh, not this, where is my presentation? Where's my presentation? Did I miss my presentation? Did I close my presentation? I did close my presentation. So let me just go to the final part of this presentation. Is just as a teaser for So after the teaser for the data extraction, which, as you see, I mean, it can get complicated, but the mapping thing we are technically relieved from that, because the tools can do this for us as long as we can feed those tools. What does it mean in terms of implementation info? So we have implementation guides that we have been designing, and we can do the implementation guides. We have the LHC forms, so the libraries to render the questionnaire, sorry. And we have Happy, and Matchbox is just another layer on top of Happy, which is actually what I showed. So the server that I just showed you is just LHC forms for rendering. Here behind this, there's a Happy server, and the server has the extract operation based on Matchbox. So that's the tool stack that we are working on, and all of that is based on the specification. So actually, to wrap up and to bring this to our scope, and to prepare for the future sessions on this, which can be on topic specific or on any architecture specific part of this, I look forward for your feedback. This is where we are. We have a Firebase Specifications. We have seen SDC as standard data capture that provides standard mechanisms, standard constraints, like this is how you do form calculation, or this is how you do form extraction, this is how you do form rendering. That is standardized for us. Now, what we have done, and I'm just going to show some example of this, we have defined case reporting fundamentals. So the things that we've discussed. If you want to do case reporting, you can do the extract operation or the definition-based extraction. We can do that. And on top of that, so we are working on a standard layer for case reporting, which embodies the architecture that we were just seeing, onto which we can start putting our standard mechanisms for patient de-identification or for patient matching. So those things that we were just discussing a few minutes ago. We can put that on this layer because de-identification will work for HIV and for cancer and for pregnancy and for COVID. And then we can make a topic-specific layer, which is HIV or cancer or any other condition or any other purpose. And on top of that, we can have the project or country-specific design. I'm just going to show you the very incomplete implementations of that. But so there is a case reporting starting thing where we see these actors, and we are looking at, okay, how does this case report submitter have to work? What data do we exchange here? And so this is the case report that we get from the forms, and this is the transform data that goes into the repository. So you see, this is an implementation of those things that we just discussed in the architecture, but this is generic and gets implemented by different content into HIV or COVID or any other implementation specific or scope specific implementation. Out of this, let me just show you the HIV implementation guide. Some of you have seen this more closely. And in the HIV, we actually have the HIV specific things. So we have the logical models, we have the questionnaires, we have some examples. So these are the specifications for HIV. So these are HIV specific. They rely on the underlying layer, which is case reporting, but they implement the HIV specific. And recently we are working on the, for example, the Vietnam specific thing. So the Vietnam specific thing, sorry, that's not the right link. Oh, that's also not the right link. Apologies for that. This is an implementation guide that has the Vietnam specific things, where in Vietnam we used the case report thing, so the form acquisition, but we also needed to get some CSV data out of this. You remember the architecture that I just mentioned, or we wanted to provide the possibility to have EHR importing data in a FHIR format. And so the CSV has some transformation of data, the form has some transformation of data, and the HR does not have transformation of data, goes directly into some sort of conversion if necessary and goes to the case report repository. So these are different layers of implementing the same architectures. So with that, I think, if I'm not mistaken, that's the teaser for in the future. We will have workshops, and you're always welcome to our fireside chats to discuss more in detail this. I would like to have your feedback and ideas on your things to discuss next, or things that were How do you feel teased? How do you feel about this session? We have a couple of minutes and I would like to have feedback, please. Speak up if you want. I'm checking the chat. Any ideas?
Throw questions in the chat. Sorry, Jose.
Are there questions in the chat?
No, not right now.
No. Anyone have any idea on which this could be applicable already? Anyone jumping to a, let me try this at home? No one working in case reporting? Anyone thinking of working on case reporting? Just to tease you some more, then, just while we wait for those ideas, as you know, we are putting some effort into making these tools as readily available for you. This is still kind of work in progress, but ideally we'll have a whole DevOps thing, like you say, this is the box. And if you put the questionnaire onto this box and the mapping onto this box, out of the box, you have a happy server, which is actually pretty much what this server does. You have a happy server with the transformation and the questionnaire out of that. So you support the transformer and the form manager if you want. So we want to make this as easy for you to adopt or your teams to adopt as possible. We are working on that and we look for feedback into those actions that we are having. Any other feedback? Any other ideas? Any teasers? Any requirements? Any needs for our next sessions? Any ideas on what we should focus next on case reporting because it's so big? Yeah, so the actual mapping of the form fields to FHIR for common use cases, we will definitely look into that. That's something that is rather important. And as you've seen, it gets easily complicated, but maybe indeed we have a mapping webinar or a workshop, maybe more of a workshop than a webinar. It would be interesting if you bring up the examples for that, and then we can work on your example instead of me coming up with a silly example of a food allergy. Any other ideas for future talks? Any other things? Oh, HIV. I'm happy to engage in that one because I'm working on that as well. COVID case reporting. We have something on this and it does need some love. So yeah, also happy to take that one. So if you don't, we'll capture those ideas, and if you follow up on the next sessions, we'll have this either on the fireside chats or a dedicated workshop. We will focus on these things. But as you've seen, much of the work is defining the mapping. Once you define the mapping, it's just a matter of doing a technical transformation, and that technical transformation is just like any development work. So there is specific skill set to transform this or to transform this picture into this, but it's development work, so it's not a hard thing. Yeah, how to implement drop-down stacks, etc. Actually, Irina, if we play our cards right, we don't need that. So if we use the standard libraries, we don't need to discuss how to implement drop-downs, unless you mean how do we tell the system that this is a drop-down box. Yeah, we will provide those examples there. It's actually quite simple. We just have to provide the right parameters when we define the questionnaire. But we should go into the SDC form definition details indeed. You have the you will have the SDC specification. Just let me look into this. Or where is it? SDC. So the part that you are after is complex form rendering, I think. Yeah, so rendering style, display, category, if it's a hidden question or not. If it's a slider, what's the step value? So you have lots of things here. Oh, and the good thing about the SDC is that it also has quite some examples. So let me see, where is this? Oh yeah, so you have some examples here. So you have lots of stuff there, and you have some examples of, yeah. So some examples of how do you do some demographics, how do you do some advanced rendering. So this is actually an example that you can look into, and out of this you have See, so this is some different outcome that you have of this. Oh, just one thing that let me just wrap this up with. For those of you who are using the OpenHIE implementation guide template, in case you don't know, we've done some time ago, we've done a change. So also to make our lives even easier, if I go to a case report form, you have, as usual, the tree view and the XML and JSON view of that questionnaire. So this is the questionnaire that we have for the HIV, but we've actually put the rendering library inside the implementation guide publisher. So you now go to here and you have the form. So this form is rendered immediately. So if I make a change to my implementation guide, I can very quickly, I can immediately, after the build, I can see how this looks like in a form. So this is, for me, it helps a lot to validate, is this really what I meant? Or is this grouping okay, or is it too detailed? So when you make the specifications using the OpenHIE template, if that specification is a questionnaire, automatically you'll see the form rendering of the questionnaire, because the tree view is interesting, but the form is, I guess, much more useful. And you'll have this out of the box with zero effort. So also wanted to mention this.
Perfect. I think we are at time now, so I will just say thank you everyone for joining. We have a fireside chat scheduled for next Friday, and we will send out an email about our next FHIR session next month in a few weeks. So we look forward to seeing you then. Thanks, everyone.
Thank you. I'll talk to you soon and see you soon. Bye-bye.